Hello everyone and welcome. On behalf of the IPVS Educational Committee, it gives me great pleasure to welcome you to this webinar series where we're going to explore vaccine and screening through a HPV behavioural research lens. Tonight we have a really exciting lineup which we're going to introduce shortly. Greg Zimet and Erika Thompson from America, as you can read there, will lead our panel, and then followed by Joe Waller and Sue Sherman. But before I begin, let's quickly look at the agenda of the IPVS Society. So our focus tonight is on the first two cells there of research, which is, to promote the translation of research results. And that's where behavioural research is so important, is taking that clinical application into the public health sphere. And so through the education subcommittee, which Mark Stebbin from Canada leads, we focus on promoting and supporting the education about HPV, and then through that, obviously, career-related agendas for both faculty, for research scientists, emerging researchers, in fact, any stakeholder that has an interest in the education around HPV issues. So without further ado now, let me now introduce my co-moderator, Professor Ellen Dalley. Ellen will be known to many of you. She's well known at our IPVS conferences, and more about that later. And Ellen is a distinguished professor and behavioural researcher. She was one of the earlier behavioural researchers looking at HPV vaccination and how we promote it into our public domains, in fact, since 2001. And prior to that, she became involved in HPV's role in cervical cancer through her work in directing women's health clinics across America, particularly New York, Michigan, and Florida. Ellen has led several large HPV-related prevention studies for the CDC and NIH, among others. She's a prolific publisher. She's published widely on HPV-related cancers, women's health in general, the HPV vaccine, and the vaccine policy. Ellen's currently a professor at the College of Public Health at the University of South Florida, where she also serves as the Associate Dean for Research. So she really walks the talk, and I'm absolutely delighted, Ellen, that tonight you're able to join me as co-moderator and you'll be leading the Q&A session later. Thanks, Ellen.
Thank you, Margaret. For those of you who don't know my colleague, Margaret, Dr. Margaret Heffernan is a behavioral researcher whose interests include Indigenous and migrant health, socio-ecological frameworks, socio-cultural educational factors, and community integration. Her work over the past decade related to the implementation of adolescent HPV vaccination has resulted in numerous awards for cross-cultural collaboration and resource developments across Australia. Margaret's PhD research was the first study to understand attitudes towards HPV vaccine among Indigenous and mixed cultural populations in Australia. The results of her study in culturally targeted education resource implementation helped contribute to high levels of vaccine uptake. So it's a pleasure to serve on this panel with you, Margaret.
Thank you.
Before introducing our first panel, I'd like to remind people that if they have questions, please use the Q&A button at the bottom of your screen, and we'll be looking at those throughout the presentations. And now I'd like to introduce our first set of speakers. Dr. Gregory Zimet is a psychologist and professor of pediatrics at Indiana University in the United States. He is also co-director of the Indiana University Center for HPV Research. Over the past 20 years, much of Dr. Zimet's research has focused on HPV vaccination. His research has encompassed behavioral, social, and politically based determinants related to the HPV vaccine. And his studies, which have included collaboration across the US and globally, have focused on adolescents, adults, parents, and healthcare providers, and include evaluation of vaccine communication intervention strategies. Dr. Erika Thompson is an assistant professor in the Department of Biostatistics and Epidemiology at the University of North Texas Health Sciences Center. She received her PhD in public health and conducted a postdoctoral fellowship at the University of South Florida. Her research focuses on behavioral aspects of HPV prevention, including HPV policy, alternative settings for HPV vaccination, and HPV vaccination among adults. Dr. Zimet and Thompson will be discussing behavioral knowledge and HPV vaccine issues, and it is my sincere pleasure to welcome both of you to this panel.
So thank you so much, Dr. Dalley, for that very kind introduction. And Dr. Thompson and I would also like to thank the IPVS Education Committee and Dr. Heffernan in particular for inviting us to present today. Our talk will focus on the broad topic of the ways in which behavioral science has a key role in improving HPV vaccine delivery and uptake. Dr. Thompson.
And I just want to share my enthusiasm. Thank you all for letting us join you today. As we get started, we do want to just point out we do have some disclosures, so they're up here on the screen. And in today's presentation, we'll cover three main points related to HPV vaccine behavioral research. We'll reflect on the importance of behavioral science for cervical cancer elimination goals. We'll examine determinants of vaccine hesitancy and describe the gaps in psychosocial behavioral research. I'll now turn it back over to Dr. Zimet to explore some of the data.
So because Dr. Thompson and I both live and work in the US, the specific research we discussed is largely focused on the United States, but much of it is in fact applicable to other countries around the world. And the framework that we will present is definitely relevant globally. At the same time, for much of the world, the issue is vaccine availability, not how to encourage people to get vaccinated. So you can see from the slide, globally, only about 15% of vaccine age-eligible girls are fully vaccinated against HPV. So behavioral science still has an important role to play prior to implementation of biomedical interventions like HPV vaccination in terms of helping to understand how to set the stage in order to ensure that vaccine implementation programs are successful. Next slide, please. So you can see from this map that the countries in green are countries that have, as of June 2020, had national HPV vaccination programs. It's important to note that these programs are not equally successful. Some of them are quite unsuccessful, some of them are very successful. So the green just shows you where those programs have been implemented. The countries that are not in green do not yet have national programs. So if we look by continent, you can see that only 31% of nations in the continent of Africa have national programs. Only 40% of countries in Asia have national programs. So we have a lot of work to do just to, if we want to eliminate cervical cancer and other HPV cancers, there's much of the world that still needs national HPV vaccination programs.
So as Dr. Zimet mentioned, we do have HPV vaccines available, and these are effective vaccines, but we need to understand what do we need to do in order to reach our cervical cancer elimination goals, especially in countries where the vaccines are available. And the World Health Organization cervical cancer elimination goals have three pillars that some of you may be familiar with related to vaccination, screening, and treatment for cervical cancer. And to help us visualize, we've considered these three goals as candles on a cake. Dr. Zimet and I are going to be using this analogy throughout the presentation today. But you may be wondering, where is behavioral science in this cake? So we see behavioral science as a foundational layer to the cake in order to achieve these three elimination goals. So throughout the presentation, you'll continue to see this analogy as we explore the layers of behavioral science and how it contributes to HPV vaccination goals. You'll also notice Dr. Zimet and I will be trading off throughout the talk as we describe some of these different levels of the cake and include some exemplar research along the way. So we'll first start off with a level that I think we most commonly think of for behavioral research and behavioral science, and that's individual beliefs. And we'll kind of go across the socio-ecological model, and individual beliefs tend to be at the foundation because this is what is a broad determinant for HPV vaccination behavior and hesitancy. So this is our base layer. We know there are various actors involved in HPV vaccination, mainly parents, but it can also involve adolescents, young adults, or healthcare providers. So it's critical that we recognize individual beliefs in the equation. So we're going to start with an example of individual beliefs that actually started some of my work in HPV vaccination that built off of Dr. Zimet's work. So Dr. Zimet and colleagues published a study in 2011 showing that healthcare providers rated a lower priority for HPV vaccination for women in relationships compared to single women. So this study excited me, and in addition to the epidemiological literature showing women in relationships were less likely to be vaccinated, it had me wondering, how is relationship status perhaps a barrier for young adult women in the US for getting the HPV vaccine when they could still catch up with the vaccine? So we conducted a qualitative study and found that women in relationships didn't perceive themselves at risk for HPV, and as a result didn't think they needed the vaccine because they were in a monogamous relationship. And we later confirmed this with other quantitative studies. So this is an example of how individual beliefs around risk perception can act as a contributor to vaccine hesitancy. I'll now turn it over to Dr. Zimet to explore the next layer of the cake.
Thank you, Dr. Thompson. So this cake has many layers, and I think it's important to note that the layers interact with each other, if you will. So individual factors are going to be influenced by social factors, which are influenced by other layers of the cake as well. So another layer of the cake that I'm going to go over here is related to the influence of family and social group norms, which can be very powerful. We know that these kinds of things can influence HPV vaccination. And it's a topic area where social behavioral science is an important role, both in identifying the nature of the influence and in designing and testing interventions that may be implemented at the family level or the social group level or social network level. And so next slide. So just to summarize two research studies that are relevant here, in 2005, my colleagues and I published a study describing research where we separately administered surveys to parents and to their adolescents, so it was parent-adolescent pairs in a clinic setting. And we asked the adolescents and the parents about intention to vaccinate. And what we found, interestingly, was the best predictor of adolescents' intention to vaccinate was their separately stated parents' intention to vaccinate. So that was particularly interesting because the adolescents didn't know how their parents had answered the survey. So again, showing that there's sort of a family culture around vaccination and attitudes about vaccination. This was reflected again in a very recent study that's in press in the Journal of Adolescent Health that focuses on COVID-19 vaccination, but again, finds the same kind of thing, that kind of family influence. And we know, that it may be important not just to address individuals in the family, but to understand the sort of family culture as a whole, as well as social norms. Back to you, I believe. Yes.
Yes. So we'll continue up the socio-ecological levels and consider the healthcare system. We recognize that the healthcare system varies from country to country, and we have a U.S. perspective, of course, for our HPV vaccine work. The healthcare system is where most vaccines are delivered for teens in the United States. And in fact, provider recommendation is one of the key determinants for HPV vaccine uptake. So while we know provider recommendation is essential, some work has explored other provider groups to be part of the equation. And Dr. Ellen Dalley, our moderator, has led that work examining the role of oral health providers in recommending the HPV vaccine, given the role of HPV for oral pharyngeal cancers. And this seminal work has found that oral health providers see themselves as having a role in HPV prevention and want to be part of that role. Similarly, Dr. Monica Castine, who's worked with Dr. Zimet, has conducted similar research with OBGYNs, who for many women are their primary care providers. So for behavioral science, we need to think broadly about the healthcare providers involved in recommending the HPV vaccine. I'll now turn it over to Dr. Zimet to see our next layer in the cake.
So so perhaps the top layer of the cake, we can consider state and national policy and politics. And we know that these kinds of things have a profound impact on HPV vaccination program implementation. Countries that have effective national policies like Australia, Malaysia, the United Kingdom, and others, including Rwanda and Bhutan, have very high HPV vaccination coverage. On the other hand, in countries like the United States, where policies are not so much national, but really state-based, the policies vary tremendously from state to state, and not surprisingly, HPV vaccination rates vary profoundly from state to state within the United States, in part based on those states' policies. The primary policy tool in the United States for vaccination is to require vaccines for entry into primary school or middle school. And that's sort of the big tool, but it's a state-based tool. And such policies have been very successful for vaccines they've been applied to. So it's important to study and understand the effect of policy on vaccination. Next slide, please. So HPV vaccine is not a vaccine that's required for school entry in most states in the United States. Rhode Island is an exception. In 2015, Rhode Island implemented a school entry requirement for children entering 7th grade, which is around ages 12 or 13. And in a series of studies that Dr. Thompson led and that Dr. Dalley and I collaborated with her on, we found that this requirement led to substantial gains in vaccination of males and to higher coverage of vaccination at an earlier age for both males and females. So what we were able to show is that this kind of a state-based policy was quite effective in increasing vaccination coverage for HPV vaccine. Back to you, Dr. Thompson.
So we'll now move on, thank you, Dr. Zimet, to the next layer of the cake that extends beyond borders, and that's social networks and social media. This is an area where vaccine conspiracies and anti-vaccine rhetoric thrive, especially in a non-fact-checked space. And I think we see it even more prominently with COVID-19 vaccination as well. So some of the work that we've done here in Texas with Dr. Jasmine Tiro at UT Southwestern has been to examine how perceptions of social media information credibility and internet verification skills like health literacy skills impact HPV vaccine decision-making for parents of teens. These online health literacy skills may be needed to filter through the information that's shared on social media or on related to HPV vaccination so that consumers of that information can help judge what is and isn't credible. We'll talk about this later, but this is an emerging area, and especially for HPV vaccine and behavioral science. I'll now turn it back to Dr. Zimet for our last layer of the cake.
So a recent challenge for all of us in so many ways has been the COVID-19 pandemic, which has led to multi-system problems, including interfering with vaccine delivery in the US and across the world, and raising the profile or the awareness of anti-vaccine sentiment. Next slide. So data from the US, and there's similar data from other countries around the world, indicates that adolescent vaccines in particular took a big hit during the COVID pandemic. HPV vaccine has declined, particularly And, you know, a lot of it has to do with parents' reluctance to take their teenagers in to get the vaccine because of the COVID-19 pandemic. And so what we found in research that's been done is that HPV vaccination declined in the US by about 24% based on insurance claims data. And a recent modeling study that was just published indicates that it may take 3 or probably more years to make up for those deficits. So behavioral science has a role to play in both encouraging parents, developing interventions to encourage parents to catch their adolescent children up to make sure that they're covered with HPV vaccine, and to encourage providers to emphasize the importance of getting back on track and taking care of those missed opportunities. But also behavioral science is going to have a very important role to play as we begin to understand more the kind of fallout from the COVID-19 vaccine hesitancy that has been so prominent, and whether that has an effect on other vaccines, including HPV vaccine. So again, behavioral social science has a huge role to play in the context of this current crisis.
So we've explored these different layers of the cake, which reflect this framework developed by Dr. Catherine Head to show how behavioral research is critical for examining the different multi-level factors that contribute to HPV vaccination. Without behavioral science, we wouldn't be able to have the foundation to support HPV vaccination goals set up by the World Health Organization. So I encourage those in behavioral science to consider these multi-level factors. So we'll spend our last couple of minutes discussing some of the gaps in behavioral research, and Dr. Zimet will start us off.
So one of the gaps has to do with closing the intention behavior gap, or chasm. In some cases, that's more of a chasm than a gap. So there's been a lot of testing of communication strategies where we've been able to demonstrate that certain kinds of messages and framing of messages can increase significantly intention to get vaccinated. What has been more difficult is to show that those kinds of interventions can actually change behavior and lead to higher vaccination rates. So this is what's often referred to as the intention behavior gap. And there is a framework, the implementation intention framework, that has been developed and tested, indicating that there are ways to close this gap. And so I think with HPV vaccination, we need to do a lot more work on finding ways to translate those communication interventions so that they don't just increase intention, but also go on to increase HPV vaccine acceptance.
And another key gap is curtailing the mis and disinformation on HPV vaccination on social media. In the past, this has been reflected as one of the top research priorities for HPV vaccination several years ago in an article, but I think it continues to be very prominent, especially with COVID-19 vaccination. So we need to develop strategies to support online health literacy skills to assist people in digesting health information. And while this process may happen outside of the healthcare provider office, exposure to social media comes into the exam room with questions from parents or patients about information they've seen online. Thus, behavioral research is critical in this ever-evolving space.
And another area where more work needs to be done has to do with implementing HPV vaccine guidelines. So as new guidelines come out, it's important that those guidelines be understood and implemented. And so we see an example in the United States where the Advisory Committee on Immunization Practices issued a shared clinical decision-making recommendation for adults ages 27 through 45 years. And that's a somewhat complex recommendation that is not well understood by providers. So we're talking about the providers are doctors who take care of adults, doctors and nurses and other healthcare providers taking care of adults, who aren't going to necessarily understand what shared clinical decision-making is. And the adults themselves may not even understand or be aware of that kind of guidance. So you have this disconnect between the recommendation and the people who need to implement it and understand it. And so behavioral science has a big role in taking those kinds of recommendations and finding ways to help to implement them through educating providers and adults.
All right.
And so this is our final slide. And again, we just want to emphasize that behavioral science has many, many roles to play and is really essential in terms of providing this foundation for these three pillars. That, the notion of if you build it, they will come has been shown time and time again to not be true. That if you build it, you need to make sure you have the foundational behavioral, social, political, and policy layers of the cake to support the pillars. And Dr. Thompson, is there anything you would like to add?
I think you captured that well, Dr. Zimet. We thank you all for the opportunity to talk with you all today.
Yes, thank you.
Oh, sincere thanks from me, Dr. Zimet and Dr. Thompson, for that very inspiring presentation through the vaccine lens, and particularly through a socio-ecological and implementation intention framework. And I'd just like to remind everybody that I'm sure there's lots of questions that came out of that. The Q&A button is there at the bottom. I'd also like to advise that we're recording this session. I know that people have beamed in from all around the globe, which is very exciting for the Education Committee. We are recording and it will be available later on the IPVS website. And also, as another goodie for participation, at the end of the webinar, you'll also be able to claim a certificate of participation, which is well worth having on your profile. It now gives me great pleasure to introduce our next panel, Dr. Jo Waller of King's College London, that is known to many of you, I am sure. For those of you who've been attending the IPVS conferences, Jo has a formidable body of work, and her colleague, Sue Sherman. So Jo has a background in health psychology and is a reader in cancer behavioural science at King's College in London. She holds a formidable career. Her profile is immense in cancer research in the UK. She had a career development fellowship. She's a visiting professor at UCL, where she worked between 1998 and 2019. Her research focuses on the psychological and behavioural aspects of cancer prevention, screening, and early diagnosis. She's a particular interest in cervical cancer prevention and has also published extensively on barriers to screening uptake, the psychological impact of HPV testing, and attitudes to HPV vaccination. With Dr. Sue Sherman, her panelist from Keele University, who's also exploring with Jo the second pillar of the IPVS Society of Screening. Sue is a reader in psychology at Keele University. She has two main areas of research. The first is exploring barriers and facilitators to engagement with cervical screening and HPV vaccination, and also a focus on knowledge and attitudes. And secondly, she also explores factors affecting vaccine decision-making, and with the current focus on the COVID-19 that Professor Zimet referred to. Sue also looks at varicella vaccination in addition to HPV. She also is a prolific publisher. Her research publications have explored the patient and healthcare professional perspectives. And currently, she is the UK delegate to the European Health Psychology Society and chartered psychologist, and the associate fellow of the British Psychological Society. So it now gives me great pleasure to turn to Jo and Sue for their presentations. Thank you.
Thank you, Margaret, for that very thorough and incredible introduction. Nice to hear all that. And hello to everybody around the world, whatever time zone you're in at the moment. It's a great pleasure to be here, and thank you to the organisers for the opportunity to speak to you here today. Let me just check I can move my slides on. Okay. So yes, for those who don't know me, I'm Jo Waller. I'm a reader in cancer behavioural science at King's College London in the cancer prevention group, which is a multidisciplinary team of epidemiologists and statisticians, as well as behavioural scientists and trialists working on cancer prevention. My background's in psychology, and as Margaret said, my main interests over the years have been in public knowledge and understanding of HPV, looking at the psychosocial impact of taking part in HPV testing within the screening programme, and particularly some of the issues around stigma and the particular impact of a diagnosis with an STI in the context of screening, trying to understand the demographic and psychological predictors of screening uptake, and then more recently the challenges of communicating changes to the screening programmes that are going on in many places at the moment. And I'd like to just acknowledge funding for my work from Cancer Research UK and Public Health England, as well as through PhD project funding.
Hello everyone, it's good to be here, and again thank you very much to Margaret for that very warm and generous welcome and introduction. So I'm Sue Sherman, and I'm a reader in psychology at Keele University, and there's a picture of Keele on the slide there, and for those of you that are familiar with the broad geography of the UK, we're based in the Midlands, halfway between Birmingham and Manchester, and just off the big M6 motorway. So I have a multidisciplinary background in linguistics, computational linguistics, my first degree. Cognitive psychology was my PhD. And over the last 12 years, I've increasingly focused on health research. So from the perspective of today's presentation, my main interests are around knowledge and attitudes towards HPV vaccination and cervical screening. But particularly focusing on both the healthcare professional perspective as well as the public perspective. And looking quite a lot of the time at barriers and solutions to engaging with both vaccination and screening, particularly with a view to addressing health inequalities. And as Margaret outlined, I've been doing, very recently, I've been doing some work also on other vaccination types, specifically on COVID, seasonal influenza and varicella.
So we wanted to also start with a map, and just to acknowledge that cervical cancer is very much a disease of sub-Saharan Africa and South and Central America. The burden of disease is very unequally distributed across the world. And this map is almost the inverse, really, of the map that Greg showed, in that the countries where disease is greatest are the countries that don't have screening and often don't have vaccination, although there are some places encouragingly in Africa where they are starting to introduce HPV vaccination. But just to acknowledge that many of the studies, again, that we're going to talk about focus on high income countries, but that's not really where research is needed, and there's a real need for behavioural science research, I think, in some of the other countries, and policy kind of research to increase the introduction of cervical cancer prevention programmes more widely across the world. Just as another sort of scene-setting slide, the landscape of cervical screening is changing quite dramatically at the moment. And so I just wanted to run through a few points on that, again, to set the scene of where the behavioural science work needs to focus. There are widespread moves around the world to introduce HPV-based screening, which replaces the cytology screening where cells have been visualised under a microscope and looks at viral DNA instead. From the point of view of the woman being screened, this raises various different sort of challenges and opportunities. A big opportunity being self-sampling for HPV-based screening, and that allows devices like the one that you can see in the picture to be used to do a vaginal swab, which can avoid the need of a speculum examination and make screening more acceptable to many women. But it also raises the psychological challenges of potentially being diagnosed with sexually transmitted infection. There are also changes associated with increasing cohorts of younger women being vaccinated, and this may mean that screening can become less frequent for many people as programmes evolve. And then I wanted to just draw your attention to this recent paper in Preventive Medicine by Weir and colleagues, which looks at some of the challenges but also the opportunities afforded by the COVID-19 pandemic, particularly in low and middle income countries. So I think in high income countries, we've seen many established screening programs being paused and then dealing with huge backlogs. due to the pandemic. But in lower middle income countries, the pandemic may in some cases have led to increased capacity for PCR-based testing because of COVID, which could then be extended and leveraged to increase the capacity to do HPV testing. And in some cases, again, there are stronger public health and primary care networks in place, which again could be used to increase the opportunity to carry out cervical screening.
So it's really vital, as Doctors Thompson and Zimet have already touched on, to include behavioural research in understanding both vaccination and screening. And in order to illustrate this here, I've just chosen one of the many behavioural research models that are available. So the diagram you can see on this slide is the COM-B model of behaviour proposed by Susan Mickey and colleagues. And what this proposes is that in order to carry out a behaviour such as attending cervical screening, people need to have the capability, so the personal sort of physical and psychological capability to carry out that behaviour. They need to have the opportunity, and that might refer to social or structural conditions, and they need to have the motivation to carry out that behaviour. And models such as this enable us to understand what barriers there are to engaging with behaviour in order that we can address those barriers and facilitate optimal engagement with the screening programme. And this can be done through a variety of mechanisms, such as shaping government policy, informing healthcare professional training, and some data from both Joe's group and some data from my group as well have recently been used to update online smear taker training, for example, and also inform advocacy work. And I'm working with a charity at the moment to look at ways in which we can reduce the barriers that exist for disabled women and people with a cervix to attend cervical screening. In order to reduce barriers to engagement, we need to understand them, and this is where behavioural research plays such an important role. And we really need to be able to design evidence-based interventions to address them. So some areas that would be ripe for this exploration that are underway at the moment is understanding preferences and uptake of self-sampling, which becomes important as countries look to supplement HPV primary testing with self-sampling schemes. We need to optimise communication to minimise the negative psychological impact that Joe referred to of HPV as a sexually transmitted infection and the stigma that's associated with that. And lots of opportunities to continue to explore barriers and facilitators to screening uptake in order to be able to reduce those barriers to engagement. And this next slide is just an illustration really that screening behaviours are amenable to change. So what you can see here on the graph on the left-hand side is the number of diagnoses in the UK. And you can see a spike in diagnoses in 2008-2009. And this came about as a direct result of the very high-profile illness and death of a television celebrity, Jade Goody. Jade Goody was a young woman who appeared on Big Brother and in fact received her cervical cancer diagnosis live on Big Brother, and then died in March 2009 at the age of 27. As a result of her death, an extra 500,000 women were screened between 2008 and 2009. And the graphs on the right-hand side show this attendance broken down by age groups. And it doesn't matter about the detail of the slide, but what you can see in two of those graphs is just circled in red is a spike. And what's important about this from a behavioural science point of view is that this increase in attendance was greatest in the under 50s. Jade Goody was a young woman, and the message that came out about the importance of attending screening that resulted from her illness had an effect, but it was primarily in those women under the age of 50. So targeted information and targeted appeals are really needed. The second thing to point out from this slide is that the behaviour change was short-lived. So there was a spike in uptake in screening, but that has unfortunately sort of dropped back down to normal levels again. And so as behavioural scientists, it's really important to find ways not only to increase behaviour attendance at screening, but also to sustain that increase.
So a lot of the work we've been doing in my group has been trying to understand some of the determinants of screening uptake, and that's included both demographic but also psychological determinants. And I wanted to highlight these two studies as two very different ways of approaching that question. You can see here a diagram from what was a synthesis of qualitative studies, so interview and focus group studies, 39 of them that we looked at, and looked at combining the findings and the themes across those studies to try and draw out what were the key factors in determining whether women choose to go for screening or not. And you can see on the left, this theme of should I go for screening was a decision about the value of screening and the relevance of screening to women. And on the right is about the process of screening itself. So screening is a big deal, was the sense in which screening can be challenging to women, both emotionally and physically. And we also highlighted the role of health professionals in determining what that experience is like. And then if women do attend for screening, that past experience then feeds back into their next decision about whether to attend again. So doing this kind of qualitative work, and particularly synthesizing findings across qualitative studies, is a way of getting a really nuanced and detailed picture of women's lived experience of screening, and trying to understand some of the factors that are off-putting and difficult for them in taking part. The diagram on the right draws on the precaution adoption process model and looks at the steps that people go through in order to take up any kind of health protective behaviour. So from being unaware of the behaviour to knowing about it but not really engaging in whether to do it oneself, to perhaps being undecided about whether to take part, and then either deciding not to or deciding to attend. And then this bit here is what Greg referred to as the intention behaviour chasm. So having decided that one is going to go for screening, you've also then got to make the decision to go. And then because screening is something that has to be repeated, people can loop back into these earlier stages. And this paper published in 2017, we did a survey of over 3,000 women and were able to allocate them to those different stages in the screening process. And that is a really useful way of, again, tailoring, as Sue just mentioned. One way of doing that is by demographic characteristics. Another way is to think about what intervention is needed for people depending on the stage that they're at with thinking about screening. So if someone is unaware of screening, then, for example, a text message reminder is not going to help them go, and there's a need for more community engagement and awareness raising. But if someone is intending to go for screening, but more practical barriers or just forgetting, stopping them from going, then things like a text message reminder or perhaps a self-sampling device posted to their home might be what they need to get them across that intention behaviour gap. So there's a range of methodology that we can use in behavioural science to help design interventions and understand and affect behaviour. And then just as a slightly different sort of piece of research that we did very closely with Public Health England, this comes back to the issue of HPV testing potentially being more psychologically challenging to women because of the sexually transmitted nature of the virus. When Public Health England did a pilot of HPV primary screening, they commissioned my group to look at the psychological impact alongside doing an epidemiological evaluation. The main outcome that we looked at was anxiety, using a very well-used and generalised measure, the State Trait Anxiety Inventory. And you can see that women who were HPV positive, whether they were just HPV positive or whether they also had abnormal cytology, were significantly more anxious than women who had negative results. And what was interesting to us is that women who had persistent HPV, so they'd had tested HPV positive and then gone back for a 12-month repeat test, were also kind of back to normal. So it seems as though anxiety is initially induced by a positive result, but over time women perhaps learn about HPV and it becomes less threatening and doesn't seem to have long-term psychological consequences. The other thing that we did within the survey was collect information from women about any unanswered questions and concerns that they had about HPV. And this then fed into extra information for women to receive when they get an HPV positive result. So it became clear from our research that when women take part in screening, they don't necessarily read all of the information and engage with it at that point. But when someone gets a positive result, that's the moment where they want to know about HPV. And so in collaboration with Public Health England, we developed some frequently asked questions and answers to them. to go on the back of that letter, so that women could hopefully have information that was clear and reassuring at the point where they really wanted it.
So you can see, hopefully, from the work that we've presented so far and some of the issues that we've raised, that although we do know quite a lot about cervical screening, there are still many research gaps. And some of those, this is not a complete list, but some of those include in targeted interventions. What interventions work for increasing uptake, particularly in marginalised or underserved groups? We've touched on age, we've touched on disability, and other examples include prison populations, homeless populations, lots of different ethnicity issues which might vary from country to country. There are also, relating back to the map at the beginning, different questions for countries according to the type of screening programme that they already have, whether it's an organised one, whether it's opportunistic, or whether in fact there's no screening programme at all. So the nature of the infrastructure poses different problems and different research and solutions that research can shed light on. As HPV primary testing is increasingly rolled out across the world, we need to work to minimise any negative psychological outcomes. And as the Wu et al. Paper shows the way to, as Jo mentioned earlier, we can explore ways to capitalise on COVID and some of those infrastructures that have been put in place very rapidly to deal with COVID in order to facilitate the screening programme. So the last slide that I wanted to talk to you through about is building on those three pillars that Dr. Thompson and Dr. Zimet mentioned at the beginning, and add a fourth one to it. So vaccination and screening and treatment are really excellent in terms of providing reducing cervical cancers as much as we possibly can, but they really need to be supported by a fourth pillar of education. And as an example of how important this is, there was a report published at the end of last year by the European Cancer Organization, which called for action to eliminate the 87,000 cancer cases caused each year by HPV in Europe and the European region in both men and women. And one of those specific action points was a call to improve both public and professional awareness and education about HPV. And that recommendation was based in part on some of the research that my group did, working with Joe's Cervical Cancer Trust, a charity in the UK. We surveyed smear takers across the UK and asked them some knowledge questions and about their knowledge also about the HPV testing, about HPV vaccine as well. And just as a brief example of our findings, we found that although the median general knowledge about HPV was pretty high, it was 14 out of 15 possible correct right answers, the range was quite illuminating. So the smear taker scores range from 5 correct through to 15 correct, with only a third of our sample getting 100% right. And from a behavioural science and an intervention point of view, one of the specific gaps in knowledge was that only 50% of our sample identified primary HPV testing as more effective than cytology first. And as we roll the HPV primary testing out across the world, that sort of knowledge gap really needs to be plugged. And that's where behavioural science can really help to identify how best to improve knowledge and uptake as a result.
We just wanted to leave you with this slide and a reminder about International HPV Awareness Day. So this is a campaign run by IPVS, and we'd encourage you all to go and have a look at the website and see if you would like to play a part in raising awareness of HPV, which I think is an important first step, certainly not the be all and end all, but an important first step in changing HPV related behaviour and potentially raising demand for preventive strategies such as vaccination and screening programmes. Thank you.
Thank you. Thank you all for really wonderful presentations. I've been over here typing and looking at things because we got some wonderful questions and questions submitted ahead of time. And one of them I think doesn't need to be answered. I'm just going to tell you because they were asking about, are there theories and models that you use in behavioral research? And both presentations had such great examples of how we use behavioral theory and how they're applied. So that one I hope is taken care of and that person's happy with the answer. There was a question for on screening, so this would go to Joe and Sue. We received a question about the presentation about how does behavior science influence those who have been fully vaccinated and subsequent cervical cancer screening?
I think that's a really good question, and I don't think we absolutely know the answer. I think there's there's been concern that if people are fully vaccinated, they may choose not to engage in screening. There's been a little bit of evidence that I can sort of bring to mind immediately from Scotland, where at the time that the HPV vaccine was introduced, women were still being screened from age 20. So there was a small cohort that they could look at vaccine uptake and screening. And the findings there were that actually it was the unvaccinated women who were less likely to attend for screening. So it seems that there's more likely to be a concentration of risky, if you like, behaviour or non-engagement with health protective behaviour, but rather than a sort of risk compensation effect of people feeling protected and therefore not going for screening. But I think there's a real need to monitor that as increasing numbers of vaccinated women enter screening programmes around the world, and to understand those risk perceptions.
Great, thank you. This is for Greg and Erika. They said, thank you, great seminar. And what about the prominent role of structural barriers as a layer of your cake? And the example is in clinical settings, where from check-in to check-out, everyone has a role in promoting HPV vaccination, but how might racism and discrimination add to those barriers that results in either exclusion or access limitations?
I can take a crack at it, and then Erika, if you want to jump in as well.
Sure.
So yeah, so structural, we couldn't cover everything, and certainly there are a lot of structural barriers in many settings in the US, certainly. Just the way our healthcare system works and doesn't work inherently has all sorts of structural barriers, whether clinics have the ability to send reminders for follow-up vaccination for the second dose or second and third dose, depending on the age. That varies. You know, the person who asked the question, I think it's Heather Brandt actually, or as part of the question, was the other issue is if you don't have everyone in a particular clinic on board, one person in a clinic, even if it's the receptionist at the front desk, can undermine vaccination. And there's a number of examples of that happening in certain clinics where healthcare providers think that their vaccination rate with HPV is extremely high, only to find that there's one individual in the office who's basically telling parents, oh, they're going to ask you if you want this vaccine, you don't want it. So there are all sorts of these issues that come into play. And that's where, you know, an approach used by some other countries can be more effective. Like in Australia, where they do school-located vaccination, you really overcome some of those structural barriers, not all of them, but it diminishes them.
And building off of what Dr. Zimet has shared about having the clinic team on board, I think this also points to structural racism, especially here in the United States, on who has access to healthcare and being able to get to that healthcare appointment, and as well as implicit biases that may happen within a healthcare setting. So these are all very prominent contributors.
Great, thank you. Let me go back to Sue and to Joe. There's a question related to the attendance in clinics declining, and you showed that nicely with the story about Jade Goody. But the question is, has a change from cytology to HPV screening led to a decrease in screening programs because of HPV being an STI? And the question is, how then would that sort of fourth pillar of education be used to address that issue?
Shall I take this first of all, and Joe, you can jump in if I miss anything. So I did have a quick look at the most recent data from the UK to address this question, and actually well, first of all, the data needs to be interpreted with caution. HPV primary testing was fully rolled out across England by the end of 2019. And obviously at March 2020, we then went into a global pandemic and the cervical screening programme was suspended for a couple of months. Having said that, the initial data out for 2020, which was up to just before the suspension of the screening programme, it looks as though actually there was no decrease in attendance so far, and in fact a very slight nudge upwards. But I think the short answer is it's too soon to say the precise impact that this is going to have. For several reasons. Firstly, there's a lot of other things going on in the healthcare sector, but also because it's not only about uptake the first time that HPV primary screening is offered, but it's about ongoing uptake. And we know from some of our research that some people in long-term relationships, for example, are suggesting that once they've been once, they might not need to attend again. And so I think there's lots of questions that will become around attendance, and the impact of this change to HPV HPV testing will become more apparent over time. And in terms of what education can do, I think we need to do more to get the message out about the importance of ongoing engagement with the screening programme. But we can tailor that messaging once we know how the change to HPV testing is going to actually affect engagement. Jo, did you have anything to add?
That's great. And I think one more question, and I do have to say the questions were great, and I'm sorry we can't do every single one of them. There's a question related to vaccine. And this person asks, from a behavioral social science perspective, does the framework of cervical cancer elimination subconsciously dissuade parents from taking the steps to protect their sons as well as their daughters? And do we need to shift messaging towards the elimination of all HPV cancers in order to attain the broadest buy-in for a life-saving intervention? So I'm turning that over to Dr. Zimet and Dr. Thompson.
Dr. Thompson, do you want to take it first?
Sure. So I think this builds nicely off of some of the work from Dr. Dalley with the feminization of HPV and how we have tried to push for gender neutral strategies here in the United States so that we can include not only girls but boys in cancer prevention. So recognizing that there are 6 types of cancer that can be prevented through HPV vaccination, I think that the person who asked the question made an excellent point that by focusing solely on cervical cancer elimination, we may lose a broader scope of including boys as well. Dr. Zimet, did you have anything to add to that?
No, I mean, I agree. I think, there are many countries that don't have the financial resources to be able to have gender neutral vaccination. I think, cervical cancer, because we have that middle pillar, which is screening, is more amenable to elimination than other HPV related cancers that can be prevented with vaccination, but there are not adequate screening methods for oropharyngeal cancer, for instance. But yeah, we have to watch, but I think, as you point out, we have to really be alert to this feminization of HPV issue and putting the burden on women only and the solutions on women only.
Great. We could go on easily for another 30, 40 minutes. I think we're out of time though. And I apologize for that. This has been wonderful. And Margaret, I think you wanted to close us out with some messages about IPV.
Will you all join me in a huge round of applause for our panelists who come from both sides of the globe? It's been a really stimulating, but just the start of a big behavioural research conversation. And again, on behalf of Mark Steben and the IPVS Education Subcommittee, I'm absolutely delighted that you've been able to join us. Ellen and I were chatting yesterday when we were looking at all the questions that had come in and said, look, we could just have a whole session on Q&A. And on that note, I know it's Mark's intention that the webinars continue next year. We'd love to see more behavioural research topics. So if you've got great ideas about what you're curious about in behavioural research, please send them in to us. You can contact Jo, Sue, Erika, Greg, Ellen, myself, Mark, any of your networks, and say we'd love a webinar on this. Now, as Ellen said, we still have a massive list of questions. So what we're going to do with the Education Committee and the 4 panelists tonight is we're going to capture all those questions. We're going to attempt to answer them, and without preempting what Mark intends to do with that, it may be that we will post them on the education link in the IPVS Society website, but you'll get an email about that if you've attended. So don't feel that, you know, we've ignored your question. Every one of them is important. It's also feeding in a lot of future research ideas. But again, really big thank you to Erika and Greg for laying the landscape around vaccine, to Jo and Sue for screening. Behavioural researchers have got a lot of work to do. And we really look forward to seeing you all at the forthcoming conference in not just a few weeks now, which will be virtually beaming out of Toronto. And if you haven't registered, you can see all the details there. And again, my very warm thanks to you. And on the next slide, there's a link there to join the IPVS and hang out for that certificate of participation. Thank you again, everyone, and take care.